Good afternoon, everyone. I'm delighted to welcome you all to this webinar on increasing home dialysis in the context of COVID. My name is Kirit Modi. I'm the president of the NKF. We have a very wide-ranging audience today. Mostly they are kidney patients and carers, and you've also got quite a few nurses and doctors, and you're most welcome, all of you. Let me start off by just going through some admin matters. So if you look at the slide, next slide. The first thing is that I'm sure most of you are familiar. Please use the Q&A button to post your questions, and we will try and answer as many of these as possible towards the end of the webinar. And if we can't answer them, we will send the answers to you in writing. This webinar is being recorded, so if you don't want to be recorded, can I suggest that you switch off your video? And I want to thank Fresenius Medical Care for sponsoring this webinar. The agenda for the webinar today is a very interesting one, and we've got some excellent speakers. So if you just look at the whole agenda, Chris, yeah? And I'll go through the agenda in a moment. Originally, we were expecting Dr. Sandip Mitra from the Manchester Royal Infirmary to be one of our main speakers as well. But unfortunately, there has been a bereavement in Dr. Mitra's family, and he sends his sincere apologies. We all know of Dr. Mitra's work over many years. He's a passionate supporter of home dialysis, and we're very grateful for everything he's doing for promoting home dialysis. The agenda, as you see, is that we're going to start with Dr. Graham Lipkin, who will give an overview of home dialysis in the UK and the impact of COVID. Then Dr. Nitin Kohli from the Derby Hospital will share the work which they are doing, the excellent work they're doing in Derby. Then we're going to look at two patient stories in terms of one home hemodialysis and one PD. Two carer stories from Brian Child and Christine Price. Then we have a few structured questions, which I'll ask the panel to respond to, and then we'll open it up for the rest of the questions. I'm just going to introduce the speakers briefly, because the details of the speakers' profiles have been sent to you before. Graham Lipkin is the president of the Renal Association, and he is co-author of the Getting It Right First Time report, which is going to be published fairly shortly. And he is going to talk about an overview of dialysis in the UK and the impact of COVID. Graham, I'm delighted to welcome you, and over to you.
Kirit, can everybody hear me?
Yes, we can.
Right, okay. Yeah, just to say thank you very much. It's a privilege to be asked to talk, and the role I'm talking in today is as renal co-lead of renal GIRFT with my great colleague Will McCain. Will's a consultant nephrologist, consultant kidney specialist in Sheffield. And what I truly believe that the renal community is at the brink of a great opportunity, and the preparation for this has been going on for 3 or 4 years now. The centre, the commissioning side of things, really now does get that renal care is important, is expensive, and that there is really quite marked variation in the care. Now, variation is very good. That's the way we learn from each other. But unwarranted variation is the focus of what really GIRFT was looking at. And it was particularly interested in excellence. So we were very keen to select exemplars of good practice, as well as maybe looking at those areas where clinicians recognize that their areas of care could be improved. And almost without exception, the clinicians themselves were telling us that when they went along. We found almost without, it was a really sort of heartwarming experience. We visited all 52 English renal units. GIRFT only looks at adults and only looks at England. And we looked we visited each one with a large amount of metrics, which I'll go through very briefly in relation to this. But as I said, almost without exception, everybody was working very hard. Everybody was trying to do a really good job and provide excellent patient care. At the end of the day, not everybody was achieving it, and certainly nobody was achieving it in all areas. But it wasn't their fault. It was the system. It was the resources. It was the training. It was the opportunities. But everybody really did want to make things happen. Getting it right first time is a way of looking at outcomes that hasn't previously been looked. In renal medicine, we're quite good at, we're quite rich in data from the renal registry, NHSBT, and other sources. But getting it right first time allowed new data streams to be looked at, which we haven't had the opportunity to link before. At the same time, there is a second process going on through NHS England, which is called the Renal Service Transformation Programme. And just prior to COVID, that was developing. And I and others in the RSTP have been very keen to link these two together, because we're all very aware of reports that sit on dusty shelves, but unless they're implemented, then we don't achieve what we want to achieve. And looking at the environment, I don't think that we have been in such a good position to really make change for the benefit of patients for a decade. And I think there will be a long time to go into the future if we don't take these opportunities. Next slide, please. So GIRFT goes across lots of specialties. Renal is just one. And there are 4 phases. The analytics phase, where we had opportunities to link hospital episode statistics to the registry, to NHSBT, Public Health England, etc. We then, as I said, visited each of the units and spent a whole session with the whole team, multi-professional members. Some patients were able to come as well. And then we wrote an individualized report for each of the 52 units, reflecting what had been discussed and what we agreed at the meeting they would focus on in the next year. We're in the midst of preparation, as Kirit said, of a national report that should come out within the next couple of months. It has to go through various NHS England limbs, but many of you will have seen it in consultation phase. And I think that there are opportunities there. And then we're also producing from each of those 52 units, each unit is excellent in something, and we produce a library of good practice so that something that the NHS is not good at, which is sharing our successes, is something that can happen and move forward. Next slide, please. So what are the big 6? What are the areas of, let's say, variation? Maybe we can discuss whether it's unwarranted. There's a significant element of variation in patient involvement and shared decision-making, and we've got good metrics on that, but clearly that's got to be at the forefront of where we go. Access to home therapies, we're talking about today. Access to renal transplantation, for those that are suitable, some of the best treatments. Wide variation in access. Vascular access for hemodialysis varies widely. And although most of acute kidney injury care sudden decline in kidney function is outside of renal and is mainly managed in general medicine, there is, as you'll see in the report, wide variation. If you were to invest time and energy in one area, and you were only allowed one area, then the biggest change that one can make is to focus on what people call pre-dialysis or low clearance or advanced kidney care clinics, because that's where the pathway converges. It's not quite so true for home hemodialysis, but for almost everything else. And then if you go into industry, it's absolutely routine that middle managers and senior managers would be highly skilled in quality improvement techniques and would be taught for leadership. And that's not something which is well established within the NHS, but clearly needs to be if we're going to improve. Next slide, please. So we're talking about home dialysis. Don't forget that's peritoneal dialysis, which is the lion's share, and home dialysis. And you're all aware of the different techniques of those different therapies. Next slide. So this is the background. This is the most recent registry report that came out a few weeks ago. And you can see in the graph on the left that the number of patients receiving kidney replacement therapy, either transplant or dialysis, is progressively increasing between 3 and 5% per year. But that's mainly in transplantation. There's a small increase in the in-center or hospital hemodialysis. And the little grey and purple strip right at the top is our PD and home hemodialysis. And if you break the pie up on the right side, you can see that the two segments at the bottom right, APD and CAPD, represents 5.5% of the total RRT population, and home hemodialysis is 2%. Now, what's happened over time? Next slide, please. If you ignore the two lines at the top, which are satellite hemodialysis and hospital hemodialysis, and just focus on the bottom, the yellow line is or orange line is the PD population. You can see over the last 10 years, the proportion of patients treated by PD has substantially fallen. Even if you add together that with APD, the grey line, so CAPD has fallen from 5% down to around 2%. APD is about the same, but there has been a significant increase that's now plateaued in home hemodialysis. And that follows, you'll remember, NICE guidance that suggested that home hemodialysis might represent 15% and various other initiatives. So home dialysis is relatively small in comparison to the larger pool. And when I started in my consultant role a few years ago now at the Queen Elizabeth Hospital in Birmingham, 70% of the dialysis patients were treated by peritoneal dialysis. And that was clearly vastly too much. But we've now gone down from 70% nationally, we're running as around 13% for PD. So big changes. Next slide, please. Now, as a community, we've all decided that home dialysis is the way to go, and the Kidney Health Delivering Excellence report that all of the groups represented today were involved in drawing up talk about self-management, preparation and choice, and the all-party parliamentary group, going back a little while now, clearly produced a manifesto for increasing home dialysis. But the numbers haven't really increased. Next slide. So why focus on home dialysis? And what I'd like to probably convince an audience that's already convinced is that home dialysis is clearly a win-win position. There's good, nice guidance looking at all the evidence demonstrating improved patient experience and quality of life for suitable people who choose home dialysis, not needing the vagaries of hospital transporting and many other reasons. Shared decision-making in studies listed below, it's clear that if one gives balanced advice in shared decision making, there is a greater patient desire for home therapies than is currently taken up. As I've mentioned, I'll show you there's unwarranted variation across the UK in home therapy rates. They haven't changed. And there's also, probably explaining some of the reasons, very significant unwarranted variation in resource and support for home therapies. We'll talk about healthcare value, and I'd like to argue that there is improved healthcare value for the system in home therapies. And if we're thinking about David Attenborough's documentary, then not taking people to a therapy, not taking people to a dialysis unit by transport 3 times a week there and back, reducing the amount of plastic is probably a lot better for the environment. And we're big carbon users in renal care. The title of the talk is about COVID, and we'll see something in relation to that. And I'll mention shared care. Next slide, please. So we've got a fantastic registry under the aegis of the RA, and have produced very accurate COVID surveillance reports in the first wave and now beyond, sadly showing us the beginning of a rise in the dialysis population again. But if you look at the proportion of total in-center hemodialysis patients who developed COVID in the first wave, it's around about 11%. And roughly around of the total amount, 3.3% of those patients sadly died in relation to COVID. Now, given the numbers of in-center dialysis, that's a lot. And overall, we've lost almost 1,400 patients to COVID across the UK. Now, contrast that with home dialysis, not surprisingly, not needing to be going in an ambulance and go to a hospital or satellite unit and be with other people. The rates are around 3%, and of that 3%, in absolute terms, about 1.1% died. So if we're looking at shared decision-making in the setting of COVID, and it's not just COVID, if the same would apply, although we haven't looked as clearly, the same would apply for influenza and other infectious diseases, then there are significant benefits for home therapies. Next slide, please. Okay, so on the right-hand side of the slide, that's the equation. That's what healthcare value, health economies tell us. So value is outcomes, and those are outcomes that really matter to patients, and we can measure those. The registry collects patient experience on an annual basis across 13 domains against cost. And the balance of those two is value. Now, Will and I spent a long time trying to look at very accurate health economics for home dialysis in the UK, and it doesn't really exist. So reference costs, which everybody uses, are unreliable. They reflect the tariff rather than the other way around. The case mix is variable. But from lots of international studies, there is certainly very good evidence that home therapies provide better healthcare value. And one of our recommendations is that a rigorous report needs to be produced. Next slide. So this is the front sheet of the report. And the reason I mention it is there is a section on home therapies, pages 50 to 61, but many of the other areas also are relevant to home therapies. So that's regional quality improvement, the access, as I've mentioned, outpatients, patient experience, workforce, diabetes, infection. It crosses almost all of the chapters. So I'll show you some of the highlights, and I warn you that this isn't the final version. I'm just giving you a sneak preview, and this isn't what will actually come out, but it's getting there. So I'm sharing this amongst friends. Please don't tweet it, otherwise I'll be in trouble. Okay, next slide. Now, you're not statisticians, nor am I, and I just want to show you how to interpret the the figures that I'll show you coming ahead. This is called a funnel plot, because if you turned it up on its 90 degrees, it would look like a funnel. Each of those dots represents an individual renal unit that's caring for you. And the line in the middle, horizontally, is the average across the country. The upper two lines, which are curving up, show that if your unit is in that area, your outcome for that area that you're looking at is higher than the national average. It's not chance, it's actually higher than the national average. And the bottom two lines that curve around to the left, if you're in that range, then you're significantly lower in whatever we're looking at than the national average. And so just bear that in mind as we move on to the next slide. Next slide, please. So this is the fundamental slide, really. So the variation of proportion of patients starting renal replacement therapy on a home dialysis therapy. And there on the left is our funnel plot. And we can see the horizontal line in the middle, 21%. So about 1 in 5 people would start. All of those dots are individual units with different numbers of patients. But if you look, then in the orange and red dots, roughly 8 units are significantly lower than that average level. So they're significantly different statistically than the rest of the units in the country. On the other side, then there are 8 units equally who balance, who are significantly higher in producing, enabling patients to dialyze at home than the national average. And the rest, the other patients in the 30s units sit within what is expected variation. So a huge variation in that. And although this isn't corrected for case mix and ethnicity and deprivation or causes of kidney failure, it's extremely unlikely that that degree of variation is explained purely on patient factors. Next slide, please. What about, so that was starting on home dialysis. This is continuing on home dialysis. So this is the variation of the prevalent, the existing population, everybody lumped together. And it's the same pattern, and not surprisingly, the units that started high remain high, and the units that were a little bit lower have become even lower. But we talked about 8 outliers on the lower end. We're now looking at 14 outliers on the lower end, and we've gained a little bit on the top end as well. But even if we took that figure of 20%, and you'll see why I've picked 20%, then 33 centers are below 20%, are below the 1 in 5. So if we want to set ourselves a target, and I don't know what the right number is. The right number is the number of patients that would want to do this and can be maintained on it. But if you chose a threshold of 20%, 1 in 5 on home therapy, then that would include bringing 33, 2/3 of UK English renal units up above that level. Next slide, please. So why is the variability? And one of the benefits of going to an individual unit, and it is quite scary being inspected from the outside, but we tried not to be inspectors. I also felt very scared when they came to us. But one of the biggest reasons when we said, well, you know, you've done fantastically well in your home therapy rate, how did you achieve that? Because we would like to share that. And most units said it's because the patients wanted it. And then when we went to the units that had, you know, 5% of patients on home therapy, and we asked the same question, they said, well, it's because that's what the patients want. They don't want any more. Now, clearly, they both can't be correct. And so there are other factors that were very clear: clinical culture of doctors and nurses, patients' culture of involvement, leadership and capacity, case mix that I've mentioned, how that advanced kidney care clinic is organized that we mentioned, shared decision making. And it's more than just I involve patients in the decision. It's quite a sophisticated structure for actually enabling shared decision making. Did the units have enough resources? I'll show you that many don't. Commissioning have not changed anything in relation to pretty much the tariff, or made any effort to adjust or change the ratios. And one of our recommendations is that commissioning should be more active if the community decide that's the way forward. And then shared care, which is the prelude in many centres to home hemodialysis, is variable, and particularly in independent satellite dialysis units for hemodialysis. Next slide, please. Okay, so this, I don't want you to look at the detail of this, but we collected data in each of the 52 units of the nursing workforce, either looking at those that have combined home hemo and PD nursing teams, or those that have separate. And the staffing ratios vary wildly. So in those with a combined team, the ratio of patients to staff was 12:1, which varied between 3 and 27:1. And likewise, there was wide variation in those that were on others. And some units were actually siphoning money from one modality of treatment to use it because they didn't have enough resource in another area. So there's very wide variation in resource being to approach home hemodialysis and PD. Next slide, please. And the same applies for the consultant workforce staffing. This is the number of dialysis patients in transplant and non-transplant centres. And the numbers don't really matter. It's just demonstrating there's wide variation. Next slide. So let's look at our advanced kidney care clinic. And we'll focus now on peritoneal dialysis. Next slide, please. So, you know, I said this is the red box is our advanced kidney care clinic. And apart from the small number of people who bypass and present in an untimely fashion, most people would come through eventually CKD and then into the advanced kidney care clinic. And this is where the changes can be made. This is where patients, where we can talk about shared decision-making, peritoneal dialysis can be encouraged, primary home hemodialysis maybe, and those people who are suitable really focus on preemptive transplant listing and live donation. And this is where the opportunity, if we could resource this, would go through. If you just click once more, we see the outline, the implant starters. Next slide. And preparation in advanced kidney care clinics is really variable. This is the PREM on the right from the registry, the most recent one, looking at shared decision making. So overall, on the bottom are all the different units, and the greeny bits are where we're doing pretty well. And overall, the numbers are pretty good actually. So patients perceive that shared decision making isn't that bad. But if you look at the pink and red areas, there is significant variation between units in what their patients perceive their shared decision-making is like. And the advanced kidney care clinics are very variable across the country. The culture is different in many. The leadership, peer educator opportunities, for example, MDT reviews, a whole host of different factors. And so that gives us a bit of a clue as to some of the factors that we can look at that would help. Next slide, please. So these are preliminary recommendations. And the first is, if we're going to get more people onto home dialysis, then we need, as a community, to ensure that patient experience and shared decision-making and planning are at the focal end of the experience. Okay, and there's a bit more detail. But if we go on to the next slide in the interest of time, we know that if you're in the low clearance clinic or the advanced kidney care clinic for a little bit longer, it gives the team time to ensure that you're more likely to get home therapy. And those 5 bars represent the number of days that the patient has been accessing the advanced kidney care clinic, so less than 3 months, 3 to 6 months, etc. And the grey bar is the home therapies. And you can see for the first 4 bars, the longer you're in the clinic and have more time to be prepared, the more likely you are to go home therapy. So getting people into into the advanced kidney care clinic, and organizing it well to be efficient is important. Next slide. So what about advanced kidney care clinics? And what we recommend is that patients predicted to reach end-stage kidney failure within 18 months are cared for in an advanced kidney care clinic and are offered all possible options. There's a lot of detail on the right, but and there's nothing surprising about that. But that clinic is really poorly resourced by NHS England, and if you really want to get the best bang for your buck and the best patient outcomes, then we need to do something about resourcing of that clinic. Next slide. What about the prevalent peritoneal dialysis population? Again, I'm showing you the same picture. Most are in the middle, significant numbers though of centres with relatively low PD numbers, and some centres of great amounts. So the mean PD rate, as I said, is 13%, but varies between 5 and 24%. And there are various factors, again, cultural leadership and resource, counselling, how the PD catheter is inserted, whether it's medically or surgically, the technique failure, how well we're able to look after patients. Some centres said, well, we transplant all our PD patients, so we don't have many. But there are centres with high PD rates and high transplant rates. And then assisted APD, which as we know is a great treatment for those who are frail or bridging whilst they're being trained. Next slide, please. So these are two factors that we picked up, and I'm not going to spend any great length of time on it, but those centres who did have a late start program, so you presented untimely, but a focused clinical team of nurses and counselling and doctors said, well, actually PD is still an option for you, even though most people would go on to hemodialysis. Those who had an untimely start program for PD had more patients on PD, and those who inserted the tube percutaneously under local anaesthetic rather than by a surgeon also had higher PD rates. It's not cause and effect, but there is significant areas. And many centres were unable to achieve the standards of the National Service Specification. So the commissioners each year or two produce a National Service Specification with standards of what they expect. The difficulty is that whilst units are not achieving those standards, there is no comeback, there is no accountability, either from commissioners or from clinicians or trusts. Next slide. Assisted APD is where healthcare staff go and provide connection and disconnection for automated peritoneal dialysis at night. It is desirable, it's increasing, it's often been outsourced to the independent sector. Units with a big geographical coverage find it more difficult, but there's really great opportunities on a network level if we join together to actually be able to address that. Next slide. Okay, so this is maintaining PD, and this is a slide of the most feared complication of PD peritonitis, and it's the major cause of admission and technique failure, and therefore conversion onto hemodialysis. And you can see that on that funnel plot again, so the recommended standard that we should all be below is half an episode for every patient per year. In the UK, the levels are quite high compared to the other European countries, and our mean sits around about 0.4. And you can see there are several centres with pretty high rates and a number of centres with really low rates that we can all potentially learn from. We're very aware that PD infection isn't given the same priority at the moment as infection on hemodialysis, where we have to hold a root cause analysis. And there is very good evidence on what reduces the risk, and there are opportunities for units to be involved in QI in relation to that. Next slide. So our recommendation in relation to home dialysis therapy is that it should be promoted and offered to all suitable patients, and that a minimum prevalent rate of 20% is achieved. And people said to us, you haven't been very ambitious. But I'd remind you that 2/3 of units would have to improve their home dialysis rates to achieve that target. Next slide. Home hemodialysis, again, much lower. And there are real barriers which units cite. Again, training facilities, financial barriers, including for newer technologies, competing PD and transplant, patient choice, etc. But again, just to show there is wide variation that's probably not explained by patient factors, and the rates vary in units between 0 and 16% of the population. Next slide. So these are the ideas. How do we make it happen? And this is where it really, I think, is the key factor. Sandeep, who is the chair of the clinical reference group for renal dialysis and transplantation, is very critical in relation to this. The 2 GIRFT leads and the Renal Service Transformation Program team. They're advertising shortly for a lead and 4 sub-leads. But as I said before at the beginning, this is the best opportunity that Renal will have to really make the changes we want. Patient charities are critical in supporting the process and that the patient's voice is heard, whether it's the patient's professional societies. You'll have all heard about KQIP, a QI process. We need networks. Renal units are too small, even big units, to work on their own and need to be able to share good practice and enable each other. We need to invest in improving. We need to give more than lip service to the techniques of quality improvement, of leadership, and more than data available. And we all need to be accountable for the changes. Next slide. So this is just one example. This is from, I've stolen this, Nitin may even show this slide, and I apologize, Nitin. But this is day life. So KQIP, which NKF is part of, involves the professional societies, it involves patients, NHS England, and it involves industry. In this quality improvement project, looking to increase home dialysis therapies, we have engagement from 3 industry partners, all willing to work together and to support this. And although the costs of running this are not massive, they are significant, and this is currently not supported by NHS. But there are real, KQIP has really taken off. It covers now 80% of the English regions and population. There are 3 national projects. It's training people and created regional networks to really be able to deliver and not talk, but actually to deliver change. Next, please. So this is some of the successes of that particular project, which Nitin, I'm sure, will talk about more. Next slide. And so we've got in renal the opportunity I talked about in the bottom left, GIRFT and renal service transformation with national service specification. We've got a fabulous registry that's supporting QI, and we've got a QI structure that has been developed over the last 3 to 4 years to deliver. And then we've got in the background the long-term plan to deliver on. Next slide. In the middle of that, regional quality improvement networks. Next slide. How might that look? Again, I'm not going to get into any detail, but that lucid chart on the left is our thoughts on what a strategic board, bringing together clinicians, commissioners, patients, data, and quality improvement to deliver what we're talking about, rather than leaving a dusty report on the table. Next slide. So our recommendation is that all renal centres adopt and are supported in quality improvement, infection prevention, reducing infection in hemodialysis and PD, and that everything is given equal priority. Next slide. So the renal the renal community I'm very proud of. It's an incredibly innovative community with fantastic resources, developing things way in advance of other specialties. Next, just click again. This is my last slide, you'll be pleased to know. So the guy on the right, Steve Powis, he usually stands next to Chris Whitty on the left of Boris Johnson. He's the medical director of the NHS. And Steve, as you know, is a nephrologist. The guy on the right is Dr. Ratcliffe, who was awarded the Nobel Prize for Medicine this year, also a nephrologist. So I think if we can create those two people with those people around, then we can actually deliver improvement in home dialysis therapies and increase the numbers for the benefit of patients. Thanks very much.
Thank you, Graham. That's been an excellent and comprehensive overview of what's happening now. And also you've very kindly shared the draft findings from the report, and there are obviously very significant recommendations there, which we'll all need to think seriously about. I'm now going to introduce Nitin Kole. He's the Clinical Director for Specialist Medicine at University Hospitals of Derby and Burton. And referring to the funnel chart, which Graham was mentioning in his presentation, I'm sure, Nitin, that your hospital would come towards the top of that because you probably have one of the best home therapies services in the country. So I'm delighted to welcome you to share how you do it in Derby.
Thank you very much. Thank you. Thank you to NKF for giving this opportunity to talk about the practice in Derby, which I'm going to focus on. Next slide. So I know everybody knows this, but I think in the context of dialysis, it is very important to realize that our kidneys work 24/7, 365 days and removes metabolic waste, but we provide hemodialysis traditionally for 4 hours, 3 times a week. And this started way back because that was, it was thought that was the optimum dialysis we can provide 12 hours a week. In hospitals, we provide that at fixed days and fixed time of the day in the hospital, and patient may have to use hospital transport or source their own transport to come to the hospital. So it is not just 4 hours on the machine, but there is an additional time coming to the hospital and going back from the hospital to home. So one has to realize that it may not be 4 hours. Next slide. So if you click again, please. So once patient starts dialysis or is about to start dialysis, they are very nervous, they are anxious, their life revolves around the hospital. And if you click again, previous anxiety then turns into frustration because now they realize that the transport which used to bring them, which is not going to bring them at exactly 7 o'clock when the dialysis is about to start and take them at 11 o'clock. They may be the first to be picked up and last to be dropped. So it may be anywhere between 6 to 7 hours on that day, and they can be extremely tired, exhausted, frustrated at the end of the dialysis. Next slide, please. So why is there reluctance for home therapy? Here I include both home hemodialysis and peritoneal dialysis, but we have to realize that the treatment at home may not be suitable for all. For many patients, who is about to start dialysis, it's an anxious time. They don't know how their life is going to change. There's an apprehension, feeling of sense of doom, and they think that if they start dialysis at home, they may not be able to cope at all. Some people also think that how will my family cope if I have to be on dialysis? They will have to look after me, and will I be a burden on my family? These things, they go into, they are there in patient's mind, and it is our duty to respond to these anxieties and questions which patients have. Next slide, please. So this is the 2018 slide, which Graham has already shown, but what we did was we encouraged our CCG to have a sequence. So the sequin was set up at 20% as per the renal registry. But we were not satisfied, and we wanted more and more patients on home therapy appropriately. And we had 38% home therapy rate in Derby. And one of the main reason was a multidisciplinary approach towards dialysis patient, whether it is in center or home therapy. But it was important to have a very important vascular access part. The MDT approach had a kidney doctor, had a vascular surgeon who would discuss and decide about where they are going to make the vascular access. And important was that once access is made for the dialysis, when I mean by access, in this case, I mean by AV fistula, it is important that that AV fistula lasts for long without complication. So it has to be monitored. And if there's a problem, it has to be rescued so that the patient doesn't require a plastic catheter put in the neck or in the groin. So we have had highest rate of home therapy in the region as well as nationally. Next slide, please. Can you click, please? Again. So the pink line shows the unit dialysis in Derby over last 5 years. You can see that there is some dip during the COVID period. Next slide, next click. So the green is the peritoneal dialysis, and this, as Graham has pointed out, over last 5 years, our peritoneal dialysis population has gone down. At one stage, we had 80 to 90 patients, and now it's roughly around 60 patients. And it is important to realize what are the causes of this and sort this out, and we are trying to do that. Click, please. This is our home hemodialysis patient. We started somewhere from 34 in January 15, and this has now increased to more than 60 patients in Derby and Derbyshire area. Click, please. We also had a satellite dialysis unit, which we acquired in September, October 2018, and these are the number of patients there. Click, please. And the white line indicates percentage patient on home therapies. That includes hemodialysis and peritoneal dialysis. And as one can see, in January 2019, March 2019, it dipped because the denominator increased because we inherited patients from the satellite dialysis unit. So the home therapy numbers had gone down, percentage has gone down, which has started to increase again. Click, please. So this is the UK Renal Registry data from 2018 of home hemodialysis patient, incident patient who was started on home therapies from the start. And Derby, we have been doing quite well, being at the top of the graph from the left-hand side. Next slide, please. And this is peritoneal dialysis modality of incident patients who have started dialysis. This is data from 2018. And if you click again, please. So Derby is again in the top 10. Thank you. Next slide, please. So what are the ingredients for successful home dialysis? And this is very important to understand. We have to understand that dialysis education is extremely, extremely important. Patients are anxious, and if they have all the information that is required, then it becomes easy for them to make a decision. Sometimes if they are just told that they require dialysis, they are not able to make dialysis, and they choose the path of least resistance of coming to the hospital so that they are looked after. One also needs a very motivated team on the home therapies to make sure that patient understands and they feel supported if at all they choose home therapy. And I think that is extremely important. We have a healthcare assistant who's band 4, who finds it as a challenge if he's told that this patient is not for home therapy. And he will ask, why is the patient not for home therapy? So he finds it as a challenge, and he takes up as a challenge. For any home therapy, whether it is peritoneal dialysis or home hemodialysis, it is extremely important to have a vascular access for hemodialysis or a peritoneal dialysis in a timely manner. And the access has to be good. If the access is not good and if patient finds it difficult to place needles in, especially when they go home, then it is bound to fail. Similarly, the peritoneal dialysis access has to be placed at least 14 days in advance to make sure there are no complications and the peritoneal dialysis catheter works properly, rather than catheter is placed, patient goes home, and then it doesn't work properly, and again it is bound to fail. The trainer is also very important. The trainer should be sympathetic. They should understand what patient is going through and level their education to the patient's understanding so that they find training easier. Then we need a very responsive and expert interventional radiologist. This is important to make sure that the AV fistula, which is made in home hemodialysis, is rescued in time. So if there is a problem, then it is quickly sorted out rather than giving a routine appointment. And then if it clots, then it creates a huge backlog, line and 3 months on in-center hemodialysis. Clearly, the technology has to be user-friendly. If it is complicated, then patients will find it difficult to use. There is always a fear of pressing the wrong button, and it has to be a very simple and easy technology to be used. Next slide, please. So the principles in Derby we have is everyone is suitable for home therapy unless it is proven otherwise. So everybody is given an option of home therapy. They have explained we have a policy of home therapies first. So patient will be given a choice of home hemodialysis or peritoneal dialysis. And we have instant availability of PD access placement. So even if the patient comes late, all of us, all the consultants, there are 11, 12 consultants now, all of them can place PD catheters. And it is not that they were trained to put PD catheters before. Once they start in Derby, we make sure that everybody does PD catheter placement and has the technique to do it. And the senior consultant will go and supervise and teach them how to put a PD catheter. As I said, vascular access surgery is very important. We are very lucky to have one particular vascular access surgeon who's really, I should say, he's an obsessive compulsive, and he has to see that the vascular access is extremely good. The surgeon, the quality in surgeon is important, that they don't think it is they should not think it is like a routine operation and then they don't see the patient. They have to, once they make the fistula, they need to go and see how their artwork has done. If they don't do that, then we know there is a problem, and that is extremely important. And sometimes these can come by reinforcement from the kidney doctors that this is the thing, and then you need to follow up, and that is very important. Needless to say, patient selection is important. You can't push somebody who clearly cannot do for a home therapy, again, that is bound to fail. So it is, again, very important. I find the home therapy nurses very important because they are the one who deal with the patients day in and day out. They are the people who train the patients. So it is very important that the team is motivated. Next slide, please. So what we do is we identify patients 2 years before they need renal replacement therapy. In our IT system, we have developed a graph system which gets extrapolated, which looks at the GFR, and it extrapolates the line on the x-axis and tells us an approximate date of when patients will need dialysis. And we transfer these patients to advanced kidney care clinic or the low clearance clinic. And this clinic is a MDT clinic where dialysis education is provided briefly. So in that 20-minute session, you can't do justice to dialysis education, but in brief, dialysis education is mentioned to them. Patient sees a dialysis education nurse who invites them for a multidisciplinary education, either on a weekend or after hours. and this is not funded. So we will call patients family, if they have friends they want to come, so we will bring them, and there's a group session. In the clinic, in the advanced kidney care clinic, they also see the dietitian at the same time, pharmacist, anemia nurse. So most of the things are sorted then and there, rather than patient has to come again and again. Next slide, please. So what is this multidisciplinary this educational session? We invite 6 to 10 patients along with the families. We encourage them to bring their family member. The sessions are organized by our kidney care team with a number of sessions of over 2 to 3 hours. And this include a presentation. A consultant will present about different modalities of dialysis. 2 different expert patients give their perspective. I think it is very important, rather than just doctor talking, patient always listen to another patients. And because there are certain things they may not ask doctors, but they will ask their colleagues, or they ask the patients what problems they can have. We also give them a talk from the PD team and sometimes from the home hemodialysis team. And we show them the kit. We show them what machines are there, how to attach, what tubings are there, how does it affect. And we also take them around the dialysis unit, show them in-center hemodialysis as well. The sessions are held once a month on weekdays, and 3 to 4 times a year in addition to weekends. And as I said, these sessions are not funded.
Nitin, I'm sorry to interrupt, but can you bring this to a close, please? Because we're running a little over time, yes?
Okay.
If you don't mind, thank you.
So I will come to peritoneal dialysis. I think peritoneal dialysis, it is very important to give confidence to patients to manage peritoneal dialysis, and teaching them importance of hand hygiene. And the main reason for peritoneal dialysis to fail is peritonitis. And it is important to realize or make patients aware about the exit site infection and peritonitis and regular bowel movements. So just, I won't go through the examples actually, and I will end the session there. Thank you. Please adjust the questions. Kirit, you are mute.
Sorry, can I say congratulations, Nitin, for the amazing work you and your team are doing in Derby. And in fact, if we could replicate that across the country, there'd be no need to be having webinars like this. So well done for what you're doing. And thank you for sharing experiences, your experiences today. I'm now going to turn to the patient stories. And we're first going to start, I think it's John, is that right? John Roberts. John is an executive member of the National Kidney Federation, and he'll share his experience as a home hemodialysis patient.
Good evening, ladies and gentlemen. Over the next 5 minutes or so, I will share with you my story about my time on home dialysis. I found out that I had kidney failure around 1994, after my son was diagnosed with a genetic kidney disease, after which further investigation found that he'd actually inherited it from me. It was 20 years later that my doctor told me that I was at the stage that I had some decisions to make. Peritoneal dialysis was not an option, as my kidneys had grown so much there was no room in my abdomen for extra fluid. Therefore, at this point, hemodialysis was my only option. In the low clearance clinic, I was given 2 options. I could dialyse in hospital, or I could dialyse at home. In clinic, I was shown 2 machines. One was used for both hospital and home dialysis. That was the Gambro machine. The other was just for home, but is transportable. That is the next stage machine. To give you some idea of the real difference in size, this is it. Well, at least that gives you an idea. After clinic, I discussed these options with the wife, as we really enjoy our holidays and have an active social life. We chose the portable machine at home, the next stage. This information was reported back to the hospital. Some months later, I was sat minding my own business in the outpatient's waiting room when a very scary nurse sat beside me and said, "John, you start dialysis training on Monday." "No," said I. "On Monday, I'm going on my holidays for 2 weeks." Immediately after I came back, I started training. It was quite a simple affair, as all the connections on that machine are colour-coded, and soon I was at home in my cell. My dialysis wing had cable TV with all the channels. I also had Wi-Fi, a laptop, and very comfortable furniture, so no shortage of creature comforts, unlike the pay-per-view option in a lot of hospital dialysis centres. The support from the hospital was great during office hours, but the backup from the next stage via a free phone number, and this is who the nurses phone when they're in the stuck, was fantastic. And it was available 24 hours a day, every day of the year, home and abroad. I soon settled down to a routine, dialysing every other day. The more often you dialyse, the closer you are to the natural function of a normal kidney. And you should avoid really going more than 1 day without dialysis, as this produces less toxins in your body, better control of your blood pressure. That's all just medical stuff. We'll leave that to the doctors. The quality of life is better, as you have control of what days and what time you dialyse. You don't have to fit in with some hospital shift system or suffer delays because Jackie is having problems getting on and always has problems getting on. So, for example, you may one day want to go to a wedding on Saturday, but that Saturday you're scheduled to dialyse. If you're a hospital-based patient, you would have to get permission from the hospital staff. "Please, can I go to this wedding?" And they're going to say no. They're going to say no because it's weekend and they don't work Sundays. So no wedding cake, no wedding, no champagne. And I have seen this happen. The home patient asks nobody. He simply swaps Saturday for Friday, then dialyses late on Sunday, has a lie-in, and reverts to the old pattern. When going away for a few days, weeks, months, communication with the hospital is really so important, and I cannot stress this enough. You absolutely must communicate with the hospital staff. Tell them where you're going to. Give them at least 6 weeks' notice. This ensures that the country that you are going to is served by next stage. The USA and Europe are pretty safe. Once you've booked, Give a copy of your itinerary to the staff so that they have a copy of your dates and your destination. If you're going on a package holiday, make sure that they are aware of what dialysis equipment you're taking with you and what next stage is going to deliver and when. Make sure that the destination is aware of what dialysis equipment you're bringing and what will be delivered the day before. Also, make sure that the airline or the cruise line is aware of what dialysis equipment you'll have. You may have it on board. The airline may issue you with a medical waiver baggage letter. Not every airline does this. Some do. Next stage will have your supplies delivered to your destination the day before your arrival. What you can see on the screen is 2 weeks supply. Don't let this picture overwhelm you. There is more equipment needed when dialyzing away than dialyzing at home. Any decent hotel, any decent cruise line will have systems in place to store the equipment and deliver to your room or cabin. They will deliver what you need on the day that you need it. And there is nothing like dialyzing in the sunshine. This is me on a balcony in Spain. Oh, whoops, cover that up, cover it up. Or dialyzing by the roadside in a caravan or motorhome. Enjoying the view, soaking up the sunsets. But I hope you found the last 5 minutes and my home dialysis story of some interest. Thank you for listening.
Thank you very much indeed, John. Now I'm going to turn to a very good friend of mine, Jyoti Jadhav, and she is going to share her experience as a PD patient. Thank you, Jyoti.
Thank you. Good evening, everyone. My name is Jyoti. I was diagnosed with IgA nephropathy or Burgess disease in 2017. My symptoms began in 2014, where I was suffering from fevers, weakness, and anemia. I started PD or peritoneal dialysis last October, where I did manual exchanges 3 times a day, 7 days a week. Thereafter, I decided to try the 9 hours a night, 7 days a week on the automated peritoneal dialysis machine because I was planning on going to work in the daytime. I received my new kidney 4 weeks ago and have been recovering at home until now. At this critical time during COVID, it is important to isolate and keep shielding to be safe and to prevent cross-infections. During the first wave of COVID, I struggled to do dialysis at home due to COVID symptoms and was taken to hospital. However, doing dialysis at home with PD was the most safest option for me. The nurses and I discussed that PD at home would suit my lifestyle, as I would have better independence and control. It was a joint decision, shared decision, and the safest option for my treatment being at home. The advantages of home dialysis are that you're in control of the management of your own dialysis and infection control. You keep your hands clean, sterile, dialysis equipment, and the surrounding areas sterile. You're in your own home. You get training in the hospital or at Baxter Training House. You spend time with your family and friends. You can dialyze anywhere at family members' houses or on your travels. You can call the PD team who will also support you. You can call Baxter Services anytime, 24 hours a day, 7 days a week for support for the APD machine. The disadvantages for me or that I noted, was you need space to store the dialysis fluid boxes. Some people may not have family or carers to support them at home. Some patients may not have the ability to set up and connect and dialyze, or the fear and of uncertainty and complications, or the lack of confidence. It could be infection and constipation. Patients with complex medical history which needs input from the medical team in hospital. So dialysis at home may not be suitable or safe. To conclude, as a past dialysis patient, home dialysis gives you greater independence and self-management of infection control. You're out of the hospital and away from infections and the viruses. And most importantly, you're spending time in the own comfort of your home and surroundings. So finally, home dialysis is a decision that's made jointly with the renal team, who will help you in making a safe and effective decision about your dialysis. Thank you.
Thank you very much indeed, Jyoti, for sharing your story. I'm now going to introduce Brian Child. Brian is the Vice Chair of the National Kidney Federation, and he's also Chair of his local Kidney Patients Association. And he will share his experience as a carer. Brian. Brian, you need to unmute yourself.
Okay.
Would you start again? Sorry.
Yes, okay, sorry. Good evening, everyone. My wife found out she had problems with her kidneys 2 months after we got married, which was 52 years ago. And her doctors looked after her until about 1985, when they had to hand her on to Addenbrooke's Hospital in Cambridge, and there they went through the process of preparing her for dialysis. She chose PD as the first option, and she had a catheter. They put fluid in, they put more fluid in, and they put more fluid in, and eventually she had a perforated diaphragm. And so after that, they stopped putting it in, and it took her several months to recover from that. You'll soon work out that Gail was a difficult patient. They tried to put a fistula in and had great problems, but she eventually started hemodialysis, 6 hours a session, 3 sessions a fortnight. And that went on for about 6 months. And then they started talking about home dialysis. They were going to build a porta cabin with all the bits and pieces inside, and all they had to do was to connect it up to the electric and the water. And they'd even arranged with the local council to close the motorway, which ran at the back of the house, for a Sunday morning and drop this porta cabin in by crane. Unfortunately, fate took a hand at that point. A kidney became available, and she had her transplant. Sir Roy Khan was actually the lead surgeon on that, and that went very well for about 14 years. And then she had breast cancer, and the tamoxifen that they gave her after, that killed the kidney off. So she had to go back onto dialysis. By then her veins were so bad that they had to give her a chest catheter, and she was on that for the rest of her life, actually. 6 months after she'd been on, they said that they could consider her now for home dialysis, and that's when I really became a carer. I had to, well, I didn't have to, but I did give up work. I was 61 at the point in time, and we decided we could afford it. So I gave up work. She came home for dialysis. She stuck to her routine sessions, 3.5 hours at a time, and 3 days a week. The original dialysis unit was James Cook in Middlesbrough. That was an hour from home, and it would take her 6 hours to be transported there, have her dialysis, and come back home. They moved her to the satellite unit in Darlington, which was 20 minutes away, and she on average took 8 to 10 hours a day for her dialysis. So obviously there was a very good reason for moving to home dialysis. Fortunately, with this chest line, it meant that there was no needling, which would probably have determined me not to do it. But once she was at home, we built up our routine. It was very good. She'd go on sort of mid-morning. I'd serve breakfast and lunch while she was on. She'd come off, she'd sit in a chair for an hour or two, and at that point she was fine. And we did that for 14 years until I lost her earlier this year, and that wasn't down to kidney disease either. We were very fortunate in that her line stayed very good. She didn't get any infection in it unless she went for an extended stay in hospital. She did it as and when we thought was suitable. As John said earlier, we could choose our time and even our place almost, because if we went away, again, she could drop into any routine that the local clinics had. We spent a lot of time in Crete for a start. Could thoroughly recommend it. The dialysis unit there picked you up in a taxi, put you straight on. When it came off, you went straight into a taxi and back to the hotel. Or I could go up with her. They had a lounge there, a swimming pool, and a cafe. And I could spend the 3.5 hours up there with her if I wanted. So that was home dialysis for us. It was undoubtedly a saviour. I don't think she'd have lasted 14 years on dialysis. Otherwise, I doubt if she'd have lasted 2 or 3 if she'd have been going to the unit all the time. So I think we've got to say that home dialysis gave her an extra 10 years of life.
Thank you very much indeed, Brian, for sharing that. Really appreciate that.
Okay.
Our last speaker today is Christine Price. I've known Christine and her husband Bob for many years. We've done a lot of work together. And Christine, it's a pleasure to welcome you. Christine has had a long career as a nurse, and she will share her experience as a carer.
Good evening, ladies and gentlemen, and thank you, Kirit, for inviting me to be part of this webinar. We've heard 3 very different stories, and now I will speak briefly about being a home hemodialysis carer. My husband, Bob, photograph just taken a few years ago, commenced home hemodialysis almost 40 years ago, and we've been married 36 years. I have journeyed along with him as wife and carer, and needless to say, there's been some stresses along the way. When I think about the carer's role within home hemodialysis, many words come to mind: partnership, knowledge, new skill, and one to be very proud of, multitasking, problem solving, but also there's stress, exhaustion, being burdened, and guilt for these feelings. But most importantly, there should be a great sense of achievement for the carer and partner together. As a nurse, I had an advantage, and like Dorothy from the film Wizard of Oz, I felt that there's no place like home. All long-term renal replacement therapies have potential side effects. And one of the main side effects with hemodialysis we know is debilitating tiredness and reduced physical stamina. But there's always exceptions to this, and there are people who are able to work full-time and dialyze at home. Over the years, Bob has become more disabled, and his main problems now are amyloid deposits in his joints, causing severe joint swelling, restricted movement, mobility and pain, and his hands are now severely affected. This was a common occurrence in people who were dialyzing 30 plus years because in earlier days, the machines and phosphate binders were not as effective. There is no doubt that the carer's role is a stressful and exhausting one, and there's lots of research to support this. Long-term carers experience greater ill health than the general population by up to 50%. The carer's health is so important, and from the onset of home hemodialysis, this needs to be recognised. I feel some short hospital home hemodialysis respite care is really important, and that when a patient goes home, this should actually be discussed between the patient carer and the home training team and incorporated into the patient's treatment plan. 1 in 3 dialysis patients will actually develop low mood at some stage, and this is truly understandable due to the many restrictions of dialysis. But once you notice that your partner is living for dialysis rather than dialyzing to live, it's time to seek help. You may need to start with the GP for advice upon how to discuss this and the issue with your partner, as quite often people can be unwilling to acknowledge that there's a problem, and how to accept help. The other issue is, unfortunately, most renal units don't have the recommended number of social workers needed, and only 5% actually have a psychologist. My motto is never refuse community support. Bob has a superb GP, and his care has included a falls assessment, occupational therapy and physio assessments at home, and now regular podiatry appointments. And of course, all these healthcare professionals have been able to offer advice, leading to improved quality of life and especially safety on mobilizing. My greatest concern is suddenly becoming ill, and I'm now a registered carer with Carers UK. If I'm suddenly ill, a care assessment of Bob's physical needs would take place within 24 hours. This has been particularly comforting during the COVID pandemic, and I was really concerned at the beginning about COVID and the whole process in March and April. Now, this brings me to home dialysis during COVID. We all know that people who dialyze at home have less infections, live longer, and this is one major advantage of home hemodialysis. At present, we feel so grateful to be dialyzing at home and able to adhere to shielding. The renal unit team have been so thoughtful about minimizing contact with us, but always there to provide support. We had some major technical issues during the height of COVID, and a new machine was needed. But I felt I was in control being at home, and being rather COVID paranoid, I could scrub the room from head to toe once the team departed. I mentioned the need for respite for the carer from dialysis, but this may also be possible with a holiday together away. We have been so fortunate to holiday in Europe, having free dialysis with the European Health Insurance Card. But alas, what will happen with Brexit, sorry. Although Bob will have his usual dialysis routine, there's no responsibilities other than it's just lovely for him to turn up at a unit and completely switch off. We also find it important to have separate hobbies and interests and belong to different associations. Bob has enjoyed helping, going into school and helping children, the 5 to 7 year old read. and I enjoy helping the young Rainbow Girl Guides. We return home with a smile and stories to exchange. Finally, there are at least 6 million carers in the UK, but we, home hemodialysis carers, belong to a very small, unique group, as there's only approximately 1,300 people dialysing at home. I will conclude by saying that I feel an important place for support and social events are our local kidney patient associations. We're a happy bunch of people. We like to socialise, maybe eat, but you will always find somebody there who can support you and your partner through your journey and really know how to empathise and understand what you're going through. Thank you.
Thank you very much indeed, Christine. Now, we have a dilemma because we've got very little time and lots of questions. So we're not going to cover the set questions, but I'd like to pick up just a few of the questions which have been asked by the audience in a moment. And we'll try and answer all of these and contact you if there are individual questions, if your name appears, because some of the questions are anonymous. So can I, Nitin, start with you? One of the questions is about staffing, yes? And the question really is what sort of ratio you have of nurse and patients for the home therapies department at Derby, and how do you manage to fund that? Because clearly that seems to be a big challenge for the hospitals.
So the staff to patient ratio is we have 3.2 whole-time equivalent currently. But when we were around 45 to 50 patients, there were only 2.2 whole-time equivalent. So it has recently gone up. How do we fund that? We fund that through our hemodialysis program itself. And we have made our trust aware that home hemodialysis is extremely beneficial. I couldn't go over the way it is looked at, but it is very important that when home hemodialysis is looked at, quite often the trust look at it as whether it is financially attractive to the trust and not financially attractive to the NHS, and that comes the problem. So when we stress the importance of that, then you can argue for the funding.
So clearly you're very successful in making your case successfully to the trust. Yes, that's the important thing. The other question again for you, Nitin, is there's been a question because we had a few questions which were sent in earlier, whether those who want to go on home dialysis, on hemodialysis, they have a choice of machine, you know, or do they have a choice, or how much choice do they have?
So we previously, say a couple of years ago, we had a mixed fleet. Patients were dialyzing on Gamro, and then we had Next Stage. And Next Stage just changed the patient's perception of dialysis. I was going to show some examples where patients have been trained on a staircase, and they've been trained within 2 weeks. So all our patients get trained within 2 weeks. The third week, they go home and they do the dialysis, and the nurse is there with them when they are doing it, just to observe how they are doing it. The Next Stage machine is so small that it can fit at the back of the car, for example, if somebody wants to go on a holiday and it is very easy to use. There are not many buttons as well. So we find we've changed all except for maybe a couple of patients now. Out of 61 patients, all of them are on Next Stage.
Are they on the Next Stage? And Graham, there's a question for you. I think people wanted to know what Sequin stood for, and to broaden that question into how do we think the commissioning process can be used as a lever for change? Because as you say, you know, we need quite significant change in so many of our units to get to the 20%. How can we use the commissioning process to bring about that change, and also explain Sequin, if you may, please?
So, first of all, really fabulous talks. The It has to come from a commissioning point of view. I've met Nitin's chief executive, and not all chief executives are like that. And so the question is, how does one convince a chief executive that this is the right way to go? And the saving and the health value is at a system level. It's not at a trust level, as Nitin was alluding to. So this is where commissioning at regional level with support can really make a difference, because the trusts themselves will struggle. But actually, if the commissioner is chasing the chief executive and saying, actually, we're not really setting a very high bar at 20%, but you do have to get to that, then it's much more likely that when Nitin or his equivalent at another unit goes to the chief executive will say yes. Sequin is just, I wouldn't even worry about the acronym, it's just a little acronym which provides additional funding through as an incentive to direct treatment in a particular way. It's not terribly effective in bringing about healthcare policy change. So the system levers and patients are particularly important in the new NHS to actually make things change. And whilst COVID has limited the amount of capacity that the NHS has, it makes it even more important that there are drivers to deliver what we think is the right thing to do, which I'm sure in this case it is.
Thank you. I'm going to bring this to a close. I'm sorry we haven't got time for to answer more questions. Chris, can we look at the last slide, please? Go past that. That's it. So a question was raised. We will be writing to you next week and send you a link to the recording of this webinar, and it will be on our YouTube channel. So that's the first thing. And that will happen next week. The next thing we're going to be doing, because as you know, the National Kidney Federation, we are a national charity run by patients for patients. And one of our important roles is to campaign for better provision of kidney services for patients. And we will be now starting a campaign to increase more home therapies in our hospitals, particularly in the context of COVID, and the evidence was very clear from what Graham and others have said. So we will be producing a report by Christmas, and that will be to send to everyone. It will have recommendations, and our plan is to start campaigning with the support of patients, kidney patients associations, doctors and nurses, because I think there has to be a shift on this. But as Graham was saying, we've had recommendations on increased provision of home dialysis for many years. And I think this is the right time. And the work, Graham, you mentioned both of the GIRFT report and of the establishing these new networks, I think gives us the right opportunity in a sense to make, if you like, a significant change. Finally, I want to say thank you to all the speakers and also to all of you for attending. There's obviously a lot of interest in this, and we recognize that, but the NKF will do all it can to try and bring about change. So thank you again, best wishes, and stay safe. Thank you. Bye-bye.